Good morning and welcome to this session titled Gray Zones in Glaucoma Management. We are trying to identify certain specific clinical situations where you have two management options to choose from. We will look at each of these two options comprehensively and then decide on the optimum course tailored for each individual situation. So we have an expert panel of speakers who will not only be covering the comprehensive latest scientific literature, but also bring their vast wealth of personal experience into looking at each of these conditions. So we will start, we'll start first of all with a very common clinical scenario that we see every day, which is occludable angles or primary angle closure suspect. So should we do a laser PI in all these patients, or is it prudent to observe some of them? So to talk us through this, we have Dr. Thomas George, a very senior respected glaucoma surgeon from Chaitanya Eye Hospital, Trivandrum. Thank you.
Thank you, Kiran. Good morning, everybody. Can I have some nice slides up? Yeah, thank you. So let's go through laser iridotomy to do or not in angle closure, primarily in angle closure suspect, PACS. So angle closure glaucoma, we have got it, when we talk about primary angle closure, we expect it to be a relative pupillary block, and an iridectomy or iridotomy is expected to be curative, and laser being easier, we do laser PI more often. Now, the questions I'll try to address is, do we need it? Does it work? Especially in the primary angle closure suspect stage PACS and PAC. Both of these situations, we do not have high intraocular pressure or disc changes. One of the first studies that we got some info on it was Velour Eye Survey. The primary investigator is right here, Ebi. And 22% of PACS progress to PAC in 5 years, and none to PACG or glaucoma with optic neuropathy. So PAC to PACG, we knew that 11% who underwent PI progressed, and 36% who refused PI progressed. So when we look at the Chennai glaucoma study, the incidence of primary angle closure disease was 4% in 5 years. That is deemed as normal. Converting primarily to PACS is in 5 years. And so we know from these two epidemiological studies that the incidence of PACG is low even in PACS and PAC. And PI does not protect everybody. It does give you some protection, but not for all. More recent evidence has come from the two studies which are popular now, and that is the ZAP and ANALYST trial. ZAP is, I don't know how to pronounce that, Zhongshan Angle Closure Prevention Trial. It screened a lot of people, 11,000 people for eligibility, and they found 870 subjects would fit their criteria. They did PI in one eye, and the other eye was maintained as a control. They had a 6-year follow-up, and all the subjects were from this particular area, which is in South China. For diagnosing PI, one of the problems there was no indentation gonioscopy was done when they diagnosed PACS. A 2-quadrant pigmented trap not visible with no PAS or disc changes, and IOP being less than 21 was our inclusion. Excluded those who had IOP rise because they had prone provocative tests and dilatation as part of the inclusion. And those who had IOP rise were excluded. Those who needed immediate treatment, such as those over 30 mm Hg, was deemed as needing immediate treatment in standard care. I don't know why it's mentioned separately, because IOP was less than 21 to start with. And 454, about half of them had OCT, anterior segment OCT, and 26.4 had residual PACS with OCT. That's about a quarter of the patients did not open up with PI. And primary angle closure occurred in 4.19. They reported in 1,000 eye years as their reporting strategy. So 4.19 in treated eyes and 7.97 in untreated eyes. So approximately half. And primary outcome occurred in 19 patients and 36 patients in the 72 months of follow-up they had. That's the absolute numbers. And this was significant. When mostly the difference was development of a PAS. So it's PACS to PAC. So it's about a half reduction that you get with PI in terms of risk. And incidence of PAC in PACS is low. We still repeated what we already said. And we go on to the next study, which was done by some of the investigators who were involved with ZAP. And so a lot of problems were sorted out at the design level itself. And it was multicentric and in Singapore. 480 individuals over 50 years, bilateral 2-quadrant apposition was required to be counted as a subject. PI in one eye, other eye control. And outcome was PAC, that's Sinike, or IOP over 21, or developing an acute closure or optic neuropathy at the design stage. Most were Chinese, most were women in this group that was studied, 92% Chinese and 75% women. And 5% of the treated eyes reached an endpoint, that is at least PAC, and 9.4% developed PAC or reached the endpoint in the control eyes. So PACS to PAC was 5%, with PI, without PI, 9.4. So the adjusted hazard ratio, which again was 0.55, once again reiterating about half would be benefiting when you do a PI. The older patients had a higher hazard ratio. So just like we talk about open angle and say thin cornea as an extra risk factor, age is a risk factor here to be considered. Higher baseline IOP again had a higher hazard ratio. So that again is another risk factor which we factor in when we eventually think about whether to do a PI or not. And the number needed to treat for the whole lot for one person to get a benefit was 22. So out of 22 patients, we prevent one developing a PAC. I'm just going through the calculation there. Okay. So now we know that the risk of progression reduces by about half with a PI and it is not eliminated. Absolute risk of progression without PI is also not very high. So at the end of the day, PACS to PAC, the risk is a low incidence, so PI can be done, or we can watch the patient and keep a patient on follow-up. Both have rationale right now. PI does not prevent closure in all. So doing a PI does not absolve us from the need for follow-up. So on a case-by-case basis, older patients and higher IOP, go for a PI. If he needs repeated dilations, go for a PI. Otherwise, you're justified in just watching the patient, keeping the patient on follow-up, 6-monthly or one year gonioscopies to see if there's a progression, and if there's a progression, intervene. Just like we do for open angle. Field progression, we get more aggressive. That sort of situation. Thank you.
We will take the questions at the end of the session because we might also have a guest speaker. So we might run short of time towards the end. If not, we will have enough time for discussion. So from PACS, let's go to the next step of angle closure disease, that is primary angle closure and primary angle closure glaucoma. So here, obviously, from the previous studies itself, we come to know that PI is a very, very good option to prevent further progression to PACG. But what about extracting the lens/cataract, whether that actually helps more than PI? So to talk about this, Dr. Manju Anoop, she is a very experienced glaucoma surgeon from Giridhar Eye Institute, Cochin. Please take over.
A very good morning to all. Thanks to Dr. Kiran and KSOS for the invite. So I'll be talking on the role of laser peripheral iridotomy versus lens extraction in PAC and PACG. As you all know, there is a significant amount of iridotrabecular contact in different stages of primary angle closure disease, and it causes a direct iridotrabecular contact or secondary to an iridolenticular contact. both laser peripheral iridotomy and the lens extraction will remove the iridotrabecular contact to a great extent if it is appositional, but both of them do not have a role if the closure is synechial. So let us look at the role of laser peripheral iridotomy in primary angle closure. So Thomas sir has already explained that LPI will relieve the pupillary block and re-establish the aqueous drainage. So this Velour Eye Survey on 5-year risk of progression of primary angle closure to primary angle closure glaucoma, they have found that 1 of the 9 who underwent LPI progressed compared to 7 of 19 who refused LPI in PAC cases. This is another report by American Academy of Ophthalmology which was published in 2018. The authors have looked at the effect of laser peripheral iridotomy on anterior chamber angle width, intraocular pressure control and disease progression, and also clinically relevant short and long-term complications of LPI. After analyzing 36 articles, they have concluded that LPI is currently considered as first line of treatment of PACD, and the available evidence indicate that LPI will help to relieve significant amount of pupillary block and widens the drainage angle. It also prevents the development of acute angle closure, and it has a favorable effect on intraocular pressure if no extensive damage. And the progression to PACG is uncommon in PACS or PAC after laser peripheral iridotomy. The complications following laser PA are not very significant and can be treated with topical medications for 1 or 2 weeks time. And another advantage is, if decided, it can be done immediately as an office procedure. However, the angles can remain closed even after LPI in case of very narrow angles at baseline, significant peripheral anterior synechiae, thick iris, increased lens vault, and anteriorly positioned ciliary body. So now let us look at the evidence for the role of lens extraction in primary angle closure. So one of the most important parameter which we have to consider, which is lens related, is the lens vault. It's defined as the part of the lens situated anteriorly to a plane drawn across the scleral spurs. It's recognized as an important factor for the development of acute angle closure also. And increased lens vault, in addition to the iridolenticular contact, it also causes a direct iridotrabecular contact. Cataract extraction for primary angle closure disease has been practiced for many years with seemingly effective results, and many studies have reported an IOP reduction up to 30% with cataract surgery in eyes with angle closure. So the lens extraction will deepen the anterior chamber, widens the angle of the anterior chamber, and it reverses the anatomical predisposing factors. However, the lens extraction has to be planned, and the patients are often skeptical of surgical options. So it may take some time to decide on the surgery. And during this time, patient may develop an acute angle closure attack. Also, acute angle closure attack can occur during the dilatation prior to the surgery. The surgery can also be challenging in case of atonic or atrophied iris or intumescent lens. Another important factor which we have to consider is the loss of accommodation following the lens extraction. Though lens extraction remove pupillary block, if the trabecular meshwork is already damaged, it will not address that. Therefore, predicting which angle closure disease patients will benefit from lens removal, whether clear or cataractous, remains uncertain. This is the EAGLE study, which is a large randomized controlled trial which looked at the effectiveness of clear lens extraction for the treatment of primary angle closure glaucoma. I'm not going into the details of the study. And this is another review article which was published in Survey of Ophthalmology regarding the role of clear lens extraction in eyes with primary angle closure and primary angle closure glaucoma. They have all included the EAGLE study also in their analysis. And they reported that though it is evident that clear lens extraction is beneficial in eyes with primary angle closure and primary angle closure glaucoma, it's technically challenging and should be performed by experienced surgeons who not only master the procedure but also able to deal with the complications. So now let us look at the evidence literature for the LPI versus lens extraction in primary angle closure. This study analyzed around 35 parameters including the lens vault, choroidal thickness, anterior chamber angle and iris specifications such as iris curvature. And they found that after lens extraction, all parameters of the anterior chamber angle were comparable to the healthy control. And after LPA, though there was an increase in the anterior chamber depth and a decrease in the lens vault, the results were comparable to the healthy control only for the iris curvature. This was a meta-analysis of phacoemulsification and laser peripheral iridotomy in the treatment of primary angle closure glaucoma, which was published in 2023. They found that phaco could effectively deepen the anterior chamber and inhibit the mechanism of angle closure, and it did not cause additional endothelial cell damage. There was a significant IOP reduction in the phaco group compared to the LPA group, and there was no significant difference in BCVA between the two groups. However, another study which was published last year on, this was also a systematic review and meta-analysis on phacoemulsification versus laser peripheral iridotomy for treating primary angle closure glaucoma, and they have reported that phaco will decrease central corneal thickness and corneal endothelial cell density, and there is no significant difference in terms of average IOP, medication usage, visual acuity, visual field progression, peripheral anterior synechia, and gonioscopic grading. So the lens extraction is curative to some degree. However, like many other surgical procedures, clear lens extraction is associated with increased risk of intra and postoperative complications and other social factors compared with the standard of care. So the decision should be individualized. So I would like to do first an LPI in case of acute angle closure and PAC or PACG with clear lens, and assess the angle after the lens LPA, and if there is significant residual angle closure which can be attributed to the lens, then do a lens extraction as a second procedure. However, in PAC or PACG with visually significant cataract, a primary cataract extraction can be considered. Thank you.
The next we'll have Dr. Kiran from Precise. MIGS is the new kid on the block, most favored right now by surgeons, most popular. And now he'll tell us its position, phaco versus phaco MIGS in glaucoma with cataract.
So a patient with cataract, now the patient is also on some glaucoma medications. Maybe it's one, maybe it's more than that. So it makes sense for the cataract to be taken out with phacoemulsification. There is no doubt that that's what we should do for the cataract. But the question is, why don't you tilt the head, tilt the microscope, and do a mixed procedure also to take care of glaucoma along with this? Now that's what we are trying to answer. It's not a very straightforward decision. So we will try to answer it through a lot of sub-questions. The first question is, does cataract surgery itself lower IOP in glaucoma? This is well established. The ophthalmic technology assessment, there's kind of a meta-analysis published about a decade back, shows that once you do phacoemulsification, the IOP comes down maximum in primary angle closure glaucoma at around 30%. With open angle glaucoma, the effect is very modest at around 13% on an average, and reduction of medication is generally possible only with angle closure glaucomas. So the next question is, does MIGS lower IOP significantly in glaucoma? This is an important question to answer because a decade back, MIGS used to be mocked as minimally effective glaucoma surgery, right? But then what constitutes MIGS? This is a matter of debate, sometimes vicious debate. The position paper by the American Glaucoma Society included procedures like ECP, endoscopic cyclophotocoagulation, and Xen implants, all under the broad umbrella of MIGS. But for ease of understanding, in this lecture, I am only looking at ab interno conjunctival sparing angle based procedures which are widely available and practiced in India. So we are looking at eye stents, excisional goniotomies with either a Kahoot dual blade or with a bent needle, or a GAT with the help of a 5-0-Prolene suture. So I'm going to look at data where there is maximum duration of follow-up as much as possible and meta-analysis wherever feasible. Let's look at eye stent inject data at 5 years. This has been available in India for quite some time. So there is quite a significant IOP reduction from baseline at 5 years and a significant decrease in the number of medications as well. Now KDB, the longest available data, is from Mayo, and they have also shown there is a significant decrease from baseline IOP at 5 years and significant decrease in the number of medications as well to nearly half. Now look at phaco-GAT in open-angle glaucoma. Again, massive reduction, around 10 millimeters of mercury in a meta-analysis with the average medication decrease of 1.67. What about angle closure and angle closure glaucoma? Because traditionally it was originally envisaged for open angle procedures but being increasingly used for closed angle glaucomas as well. The average IOP reduction is about 7.7 and medication decrease 1.57. All the green tick marks basically indicate that these are all statistically significant. But now we already know that phaco reduces IOP, phaco plus mix also reduces IOP. But what happens when you pit both of them against one another? That is when things start to unravel a little bit. So this is what we are trying to answer. This is the ophthalmic technology assessment published 2023 by the American Academy. 10 studies were analyzed. Phaco mix only produced an additional 4 to 9% IOP reduction over phaco alone. And 4 to 9% in most circumstances would be considered like a placebo-like reduction. And it will eliminate about one medication. But there are two important caveats I kind of found when I looked at these results. One is that in this particular study, the phaco arm alone accounted for nearly 21 to 28% IOP reduction, which kind of dulls the effect of phaco mix. Now, in open angle glaucoma, we generally don't experience these kind of IOP reductions on phaco alone. In fact, I had already shown you an OTA in 2015 which showed that the average reduction is only 13%. The second thing is this was a very stent heavy study because all the 10 studies, you had 9 out of the studies looking at stents alone, eye stents and hydrous, and only one excisional goniotomy and no GAT. So that will also kind of influence the results a little bit as we will see. A meta-analysis on phaco versus phaco eye stent. Again, no meaningful IOP reduction over phaco alone. Again, the caveat here is that 8 out of the 10 studies looked at older generation eye stents, not the newer ones. I'm not even talking about the Infinity, but the injects were only in the 2 studies out of 10. This will actually look at phaco versus phaco stent versus phaco goniotomy versus phaco GAT. It will give us an idea of the relative efficacy of these procedures. The meta-analysis published in 2024 with some material also additional published in 2025 showing that control here is phacoemulsification. TM bypass refers to stents on an average 3 millimeter reduction. As you go to both excisional goniotomies, this includes both KDB as well as Tanito, around 5 millimeters of mercury. GAT produces the maximum result at around 9 millimeters of mercury. What about angle closure? Again, here the effect of phaco alone becomes very significant and not surprisingly, when you compare phaco versus phaco mix, the average IOP reduction is not statistically significant. You can see that the confidence intervals are crossing 0 there, and the average medication decrease does not also attain any statistical significance. Now, phaco has a stellar safety record. So, addition of mix, does it introduce new complications? Obviously, yes. Hyphema is a common companion of any angle-based procedure. It generally tends to be the lowest with stents according to reported literature and highest with GAT. So with the increase in manipulation of the angle, the rates of hyphema tend to increase. Other complications like IOP spikes and PAS have also been described. We're not really sure how much this PAS contributes to failures later on. Serious adverse events, at least in this study, was found to be nil. Now you can also have device-specific complications which are related to the stents. So obstruction, occlusion, malpositions have also been described. An interesting thing, whether it is clinical significance, we don't know yet, but in a post hoc analysis, the hydrous implant had about 9% endothelial cell loss compared to about 3.5% for excisional goniotomy with KDB. Now, the safety profile of mix compared to TRAB is obviously, or TRAB or tubes is obviously great, But compared to phaco, you have to understand that serious complications can still occur, and they tend to be more for GAT versus goniotomy versus stents. So this paper from LVPI, so they kind of enumerated all the complications, the minor and the major ones, and you find that the list actually includes cyclodialysis, macrohyphemas, corneal decompensations, vitreous hemorrhage, hypotony. In fact, while not explicitly mentioned in this, there have been at least 2 case reports of wipeout following GAT procedures, and 1 case of wipeout even after a KDB. And the other thing, I have now bombarded you with a lot of literature and statistics. Now, I will also look at whether addition of mix to phaco alter the patient experience, because phaco itself gives a generally very good experience to the patients. They are generally done under a topical anesthesia, and the visual recovery is very fast on day 1. So when you're comparing phaco versus phaco mix, and in counseling, it's important to sometimes prepare patients for what might actually happen. Now, at least in my case, as you go to GAT, all the GATs I perform under peribulbar block. KDBs I perform about half under topical and half under peribulbar block, depending on how the cooperation of the patient is assessed preoperatively. So it is important sometimes to tell them that you might be giving a local anesthesia, because they are expecting a no injection surgery when they are coming for cataract for this time. Similarly, in terms of visual recovery, cataract day 1, you will have you are expecting, the patient is expecting a recovery on day 1. So you kind of think, okay, transient hyphema is not a major complication, it's a major complication for the patient, because it might take 2 or 3 weeks to recover. So these 2 have to be counseled pre-op. Now, the guiding principles from all this is, in open angle glaucoma and cataract, if it is medically controlled, the standards are very high. So you look at the severity of glaucoma and the number of medication the patient is on. In the lower end of the spectrum, you might get away with phaco alone. But as you go up the spectrum, you will have to add on a mixed procedure like stents, goniotomies, or GATs, depending on a lot of things, economics, the degree of IOP reduction you require. And in medically uncontrolled POAG, phaco alone is not going to cut it. So depending on how much of reduction you want, you might have to add on a mixed procedure. If you require somewhere like 30% reduction, more often GAT will help you than otherwise. In angle closure glaucoma with cataract, if it is medically controlled, a lot of patients can be treated by phaco alone. And only a very small percentage of patients will require an add-on procedure. Generally, goniotomies and GATs perform better than stents in angle closure so far. And medically uncontrolled, again, up to about 10 to 20%, we might be able to get away with phaco alone. And then at higher ends of the spectrum, we might have to add on a procedure. I have important 2 caveats, because I have put in a lot of literature. One is the heterogeneity of the studies. The failure rates for a single procedure like GAT can be as low as 3% in a certain study and 48% in another study. So you think whatever you want out of that, and there does not seem to be any consistent predictors of success. And the quality of the published studies, that relieves a lot to think about, because we look at the guidelines, you will find that the industry bias is too strong here, but 1/4 of the studies have an industry employee actually being one of the authors. So keep everything in mind. Thank you. So when you have newly diagnosed POAG, should we continue with our standard medical regimen, or should we go in for an SLT? So to talk about this, we have Mr. Ravi Jacob. He is officially a non-member of KSOS, but considering the fact that he has been a part of our KSOS instruction courses for so many years, I think he deserves an honorary membership. And he is a consultant at the University Hospital Southampton and New Medica, Hampshire. Over to you, sir.
Good morning, everybody. Thank you, Kiran, for organizing this very interesting session and this very good talk of yours earlier on. I'm going to talk to you about medical management versus SLT. And I'm probably tilting more towards SLT, as you will see in my talk. The usual disclosures. It's always a pleasure to be back at the KSOS. Unfortunately, someone who will not be back with us from now on is my good friend, Andrew, who unfortunately passed away about 6 months ago. He used to be a sparring partner, mentor, everything. So we all know that compliance is a major problem whenever we are dealing with glaucoma. And we do know from previous studies that a lot of patients, especially in areas where patients have to refill prescriptions, you know that about 90% of the time prescriptions are refilled, but there is the odd missing out of the prescription. Moreover, we also know that 6 months down the line, a lot of patients do actually stop taking treatments. The reasons for this are very obvious for anyone who does anything with glaucoma patients and gives them drops, and that's a whole list of side effects that you can see. And the newer drops haven't really made any difference to the side effect profile. They all are bad enough. This is a classic case, someone whom I have operated on. It's only after an operation that the contrast becomes very obvious. Suddenly, the other eye is looking horrible, red, and you can see that there's a bleb that is lifting the lid here in this poor lady. And it's not surprising not to get a good bleb in someone like that, because that would have been the situation when you were operating on this lady. It is very difficult to even see the superior aspect of the globe, and this is where I love the pedibulbar block, where it gives some orbital volume and brings the eye up for you to operate on. Again, I don't have to go through with the reasons for compliance, but we are guilty of very complicated treatment regimes as well. And this is one of my patients who came with a whole list of medications. And that's what she's currently on, but this is what she's been through. And that's just about any drop that is possibly available in the UK. So SLT is very attractive in patients, therefore, because it gives you an opportunity for a one-off treatment. The laser treatment is selective. It targets the melanin in pigmented cells, and it stimulates cytokine activity, brings in macrophages to sort of remodel the trabecular meshwork so that the trabecular meshwork actually gets a new lease of life. The beauty of the SLT as opposed to the ALT that preceded this, I mean, most of you are far too young to know what ALT is, possibly. But the ALT had to be focused exactly at the right spot. And it was a coagulative laser where it used to actually damage the trabecular meshwork. In contrast, SLT doesn't alter the trabecular structure as such, or at least the framework as such. The cellular structure may change. We don't really see it happen. It has a very good side effect profile. When I do a SLT laser, what I tell the patient is that they might feel an odd sensation a day or two. It's not usually the day of the laser. Usually it's the next day or the day after that they can feel a little bit of a headachy feeling or a heaviness of that eye. I only do one eye at a time. Like with all lasers, it's good practice. There is a small chance of an IOP spike. The chance increases when people are enthusiastic and they tell patients to stop their drops immediately after the laser. It's always better to keep them on their, if they are on drops, to keep them on their drops for at least till you have your first post-operative visit. It gives a very powerful intraocular pressure reduction. It is comparable with latanoprost as a first line of treatment, about 30% of intraocular pressure drop. And therefore, there is evidence there, and there is a study from Katz et al. Moreover, it's sustained. It can, I mean, this study shows that it goes on for about 18 months of sustained intraocular pressure lowering. So again, you get a good drop and you get a sustained intraocular pressure control. Therefore, the National Institute of Health Research in the UK spent about £2 million to fund this study to compare SLT versus drops. It was a large study, went on for about 5 years, actually went on longer than that. 6 centers, 2 arms, one with the eye drops and the other one with the SLT. And they treated in pursuit of the target. So they established a target intraocular pressure and tried to achieve the target by either repeating laser or increasing the drops in the drop group. Endpoints were intraocular pressure as expected, disease control, and the need for surgery. And the good thing about this study was that at 3 years, they found that fewer drops were required, fewer surgeries. In fact, there was no patient from the SLT group that required surgery. And to make it attractive for the managers, it costs about £450 lesser to treat someone with SLT as a first line of treatment. Therefore, they recommended that this should be the first line of treatment. So 2-month reduction of about 30% in both groups actually. But the most important thing is no trabeculectomies here. Treatment escalations, that is retreatments, were required in a small number in the laser group, but in the medicine group, a lot more. Disease progression was worse with the drops. And it's also useful to have a look at data from elsewhere. This is just data from the UK. So this is a study from East Africa that showed a similar sort of outcome. This time it was in comparison with timolol drops because Salatan is not that freely available maybe at the time of study. So in response to this study, the National Institute of Clinical Excellence in the UK, which advises all of us, changed their directive to say that it should be given as a first line of treatment in open-angle glaucoma, newly diagnosed open-angle glaucoma. Subsequently, the European Glaucoma Society and the American Academy also sort of fell in line. We had a little audit of about 100 cases that we did at Southampton just before this recommendation came out. Over a period of a couple of years, we looked at our patients, 100 cases. 60% of them were open angle, 11% were ocular hypertensive, few angle closures, must have been post-op, cataract, so after the angles opened up. And we found that there was a good response to the open angle pigment dispersion and the pseudoexfoliation group, less from the normotensive group, and slightly lesser from the angle closure group as well. Same thing, similar responses from in the absolute numbers of intraocular pressure drop. So we come back to the original question: is it a practical first line of treatment? We know that there's a 50% non-adherence with traditional medicine, and the thing would be the side effects as far as I'm concerned. Of course, the cost is an important factor, especially in a country like India. The advantage here is that you control it, but the downside is that this is a glaucoma doctor delivered treatment, and it is a bit of a tiring procedure. There is a new machine on the block. This is the Belkin. It has been taken over by Alcon of late. So this is a non-contact laser, 120 pulses, as compared to the conventional SLT when you have to apply a contact lens. Because it has to penetrate through this much of tissue, you have to give a slightly larger dosage of laser so that you get adequate exposure there. But it is automated. It tracks the eye. It gives more burns. But unfortunately, you have to use a speculum. And we all know that when you put a speculum, you don't often see all of the angle. So, back to the question. This is the downside. Ocular surface disease is a big problem as a glaucoma surgeon. Big advantage here is that it is repeatable. It has a good sort of proven track record efficacy right now. And therefore, I would seriously consider SLT in open angle glaucoma patients of yours. Thank you very much. Thanks for listening.
Thank you, Dr. Rabi. I'm sure a lot of people have questions, but we will take it at the end. We go for the final lecture. We have a patient with primary glaucoma who needs a filtration surgery. So is your first filter going to be a trab or a tube? This is for primary glaucomas. Dr. Bindu Ajit, she's a very experienced high volume cataract and glaucoma surgeon from Comtrust Eye Hospital, Calicut.
Good morning, everyone. Thank you, Kiran, for this opportunity. Like Kiran told, it's a primary open angle glaucoma, and the two surgeries offered are the trabs and the tubes. Now, when you have multiple options, the consideration you take into account is definitely the outcome, the efficiency of the procedure, and safety of the procedure, and the most important, the ease of doing it, or the technical skill of the surgeon matters the most, the learning curve, the cost and affordability, and how often can you repeat it, and most important, what is the evidence that literature has. Now, trabeculectomy remains the gold standard and is the most commonly performed surgery. But then, it is usually what we intend to is to get a low target IOP, and it is repeatable, and at least in this part of the world, it is the most, like, everyone is more familiar with this procedure, and you have much more literature on this procedure. But we do know it comes with a lot of complications like hypotony, hypotonic maculopathy, the suprachoroidal hemorrhages, and bleb-related infections. Like, though we use the same amount of mitomycin for the same amount of time in different patients, they react differently, and it is not the same type of bleb that we get in all patients. It can vary from the cystic to thin-walled blebs, and that is the reason why it ends up in all these unpredictable results that we have. So that is why it is not indicated in all type of glaucomas, especially we need a lot of post-operative interventions also. Though we have the modifications where the efficiency can be increased by the modifiers like the mitomycin and 5-FU, and also with the use of releasable sutures, yes, definitely we can improve the efficiency, but it also comes with its own complications of the antimetabolites. So that is when we move on to look for a different surgery, that is the glaucoma drainage device. We have both the valved and the non-valved. It was usually previously reserved for the refractive glaucoma, but now we more into primary glaucomas too. And because it's a safer alternative to trabeculectomy, and there is a shift in trend towards the GDD. Initially, it was considered unsafe, but now we have more of this with the scleral patch graft and with the stents that we put the supralone and the supramid sutures, efficiency can be increased and the complications can be decreased in the GDD group also. Now, when we look at the trends, initially the trabs were on the rise, but now we see the trabs are on the down. And both for the primary and the secondary, the GDDs are on the rise. That is what literature says. Because the GDDs gives you a more consistent outcomes, and it is more posteriorly located blebs and with lesser post-op interventions and less risk of endophthalmitis. And the most importantly, like what the previous speaker told, the ocular surface disease, where the trabs outcomes are not very favorable, this comes in handy. And especially when you have a thin sclera or patients with rheumatoid arthritis where trab is not favorable, primarily we go in for the GDDs. And the complications of the post-op medications, the scarred conjunctiva, the scarred, there also GDD comes to our rescue. Initially, GDD was used only when you have a refractory glaucoma where the post-retina surgery or a failed trab. That was the time when we used to reserve these GDDs too. But the side effects are or the drawbacks are it has a more steep learning curve, and the cost. but now we have the ADI valve, which is cost effective. And to repeat a GDD is more complicated than to repeat a trap. That is one drawback. And then the evidence when compared to trap is less. And we do have complications, yes, we do have complications of GDD with a tube exposure, with a tube endothelial touch and the damage, hypotony. All this is also there in the GDD. And especially the time taken to do a GDD is much more than what you do a trap. So that is why initially GDDs were reserved to the uveitic glaucoma, the neovascular glaucoma, or the secondary group of glaucomas. Now we'll just see what the evidence shows as a primary tube versus trap study, which we have both the 1-year result, the 3-year result, and the 5-year results are out. What does this say? It was a multi-center study with 16 centers, 242 patients, 117 underwent trabeculectomy and 125 the bowel implant. And then what is the 1-year result was trabeculectomy with mitomycin had a higher surgical success rate than the tube implantation, but the trabeculectomy people and the serious complication producing vision loss requiring reoperation was lower after tube. The trabeculectomy group had more complications. And this was same in 3 years also, but the difference between the IOP control between the two group was not significant. Again, the serious complications was more in the trap group. And 5 years, again trabeculectomy with mitomycin and tube shunt surgery produced similar IOP, but the trabeculectomy group had fewer glaucoma medications after the surgery, and there was no significant difference in the rate of surgical failure between the two groups. So that was the statistical results. Actually, the difference in IOP was only around 2 or 1, and the medicine difference was 2 in one group and 1 medication in the other group. There was no much significant difference, and the complications they looked into was more of wound leak in the early stage in the trabeculectomy. So that is why the incidence of complications was more in the trap group. So complications were more of hypotonic maculopathy, was 2 in trap group, and that is why the vision loss is more with the trap group. Again, another study which also showed similar results, that two group had similar IOP control. There was no much statistical difference between the two group in a primary glaucoma. And this is a practice preference of glaucoma surgeon, a survey done in American Glaucoma Society. The use of GDD has increased and that of trap has come down concurrently, but still trabeculectomy remains the most popular primary incisional surgery performed. So now to answer whether you'll do a trap or a tube in a primary glaucoma, definitely we'll all go with, I think at least in this part of the country, we go with a trap in uncomplicated primary glaucoma, except when you have a scarred conjunctiva or you have scleritis or scleromalacia, and when you have more risk of hypertony or you have like a risk of expulsive hemorrhage like the Sturge-Weber, there you go for a glaucoma drainage device, especially the valve device, rather than going for a trap there. Thank you.
Yeah, so we have about, I think, 5 minutes for discussion. If anybody has any questions, please feel free to ask. You have mics left there. Do you have a...
Forgive my ignorance about glaucoma, but do you factor in that lens rise thickness when what you measure in OCT, no lens vault,
OCT.
in your decision making regarding a angular closure glaucoma?
Okay, we do measure the lens vault. That's what you are trying to say, and it is, though we don't have an absolute cutoff, it is believed that something above 1 millimeter vault would be a rationale to go after the lens as well in closure. And having said that, most of us would go for a PI. It doesn't work. We look for a cataract, we find a cataract, even if it's just about there, then we tell them it's good to get a cataract surgery. A absolute clear lens, we think 10 times before we actually get it out. And one of the reasons is doing a cataract in this extremely shallow eyes is also asking for trouble.
In our case, we usually don't think too much between PI versus lens. You know, we can always do a PI first and then think about the next option. That question of PI versus, the other thing is really not a big issue.
No,
the
there's-
exception would be actually in when you have a significant cataract also in a particular patient, then why should we do a PI is the only question. I think in the discussion yesterday also in another panel, the only reason then you will have to do a PI is when you require a complete pre-op evaluation where the disc is otherwise not visible in an undilated pupil or all, where we want to dilate and the angle is scary looking enough to make you want to think twice about dilating. Otherwise, in such cases where there is a clear-cut cataract, we'll obviously take out the cataract because the effect of cataract on the angle is many, many times better than PI alone. But in other cases, as you said, always PI first and then there is no question of PI versus.
The thing is, PI is almost innocuous. That's why. The real question is, do a PI, the pressure is not controlled, you got a lens that's huge, and you're debating whether to do a trab or a lens. When you're already committed to surgery. And let me put one thing to you. That is, we do not have a tube in India which is less than 400 microns thickness, and we do not have that 400 microns in the angle. So invariably we are touching the peripheral cornea. How often do you have to go for a endothelial transplant or whatever with a tube, because your center does do a lot of tubes?
Yeah, the literature is actually very clear that if you look at retrospectively the number of endothelial transplantations on patients who have undergone trabs or tubes dominate, 100% dominate. I have one question.
Yeah. No, I'm pretty scared of tubes, honestly. So I think you have to think of a transplant if the patient has undergone a tube. It's almost like that, because I think there is definite endothelial damage, 100%. And it's long-term also.
Yeah.
That's why we are all waiting for the Paul's tube to be
The lower
surface
area.
the lower diameter, overall diameter is much less.
I
Hopefully, it'll
have
be
one
there.
question for Dr. AB.
There is also the pressure flow,
Pressure flow.
which will be coming, I would think.
Yeah, Dr. AB, the thing about mixed procedures, GAT, and now it is a big debate because you see one major teaching hospital in India absolutely hates GAT and does not perform it. One major teaching hospital performs kind of only GAT. So what is the experience that you guys have in the UK with respect to?
Yeah, we don't do GAT the way you guys assume. We have a device called the Omni device, which we use to do the GAT. It makes things a little simpler, but GATs can misbehave, and they can misbehave very badly, and they can bleed. Bleeding can be quite significant to the extent where now, if someone is on a blood thinner, we don't do something like a GAT. If someone is on a blood thinner, we go straight for the eye stent if we have to do something. That is probably the safest. It may also bleed a little bit, but that is controllable. That's not a problem. The problem with the GAT is, I think you showed it in your data, that 48%.
Yeah, the success rate widely varies on publication.
That 48% is a big worry, to the extent where when you have other alternatives, you'd rather go for the other alternatives than go for something with this wide a response. There are patients who surprise us, do very well, and there are the patients who you wish you hadn't
The
touched.
spectacular successes and the spectacular failures.
Failures. So you just wish that you hadn't done something of this
I
sort.
can take it on. I have done a fair number of GATs because I was going for the cheapest alternative for the first 2 years of my MIGs. It was all GAT. And at least half the patients have got a discernible hyphema in the first 1 week, dispersed hyphema at least. Very few have layered. And one fellow had a high fever for 1 month. And at the end of the month only, he confessed that he lied to me that he had stopped his ecosprin for 5 days because he thought the heart was more important than the eye. And he was still taking ecosprin while the blood is there, and I'm wondering whether to evacuate at 1 month. That can happen. So GAT can bleed. All the MIGs can bleed, but GAT can bleed fairly profusely.
11:55. It's actually kind of
And
tight.
worst case scenario, if the blood gets into the bag, then you have to do a YAG to clear that up. So it is solvable, but it causes a lot of anxiety.
This particular patient has got an in the bag high fever, luckily in the lower 1/3, not visually significant. It's staying there.
But the Omni doesn't actually rip out the mesh, it only dilates, right?
Oh, you can use it to report as well.
Okay.
You can dilate or report. So what we used to do was 50-50. Get the best of both worlds. But it doesn't. And report one half. And we used to do it top or bottom, but now we tend to do it on just the nasal 180 when we are ripping. The one other thing that I would add is in angle closure cataract, I always do an intraoperative gonioscopy to just make sure that the angle is open. You can easily open up that angle while you are there, and it gives you a far more predictable outcome.
That concludes our IC. We have left the stage right on time for the next people. Thank you.